Good evening, everyone. This is Dr. Richa, and today here we are for the CCI Lung Carcinoma webinar series, where we are going to do in next 60 minutes to we will be having a case-based discussions on various um, lung cancer cases. The cases have been shared by the panelists here, and I wanted to tell you that it is today's in the world of precision medicine and the way the medicine has advanced, it is very, very important to have a multidisciplinary approach for any disease. We know how in interstitial lung disease the MDT works, and same stands for the lung malignancy as well. So, without wasting much of the time, I would like to invite and introduce the panelist for today's uh, case-based lung cancer discussion. We have a Dr. Chandrashekhar, who's a medical oncologist. We have Dr. Sukhram Bishnoi, who is a thoracic surgeon, specifically doing more of the oncology surgery. Dr. Deepak Agarwal, who's in radiation oncologist. Dr. Gaurav Sahu and Dr. Prajay Lunia are the pulmonologists. So I welcome all of you on behalf of CCI and Cipla. And shall we start off our case-based discussion on the cases?
Hello, am I audible?
Yes, you are audible, Dr. Agarwal.
Chandrasekhar has not joined because he is finding some problem with the link. I am sharing him the link and he will join in a couple of minutes.
Who is that, Dr. Deepak?
Dr. Chandrasekhar.
Oh, Dr. Chandrasekhar hasn't joined yet. Okay, sure.
I have shared him the link. For 1 or 2 minutes, he will join.
Right. Shall we, in the meantime, start discussing our first case? And while Dr. Chandrasekhar join us, we will be taking his opinion as well.
Yeah.
So our first case is shared by Dr. Deepak Agarwal, who's a radiation oncologist. And I'll just go through the case. We have our apologies that for this patient, we don't have the initial imaging because the patient, when presented to Dr. Agarwal, didn't had the imaging with him. Sorry. He's a 69-year-old gentleman, hypertensive, a reformed smoker who has history of cough for last 2 years, and for 6 months he was symptomatic with loss of appetite. So his CT chest report he was having, which shows an area of consolidation in left lung involving the apico-posterior segment of the upper lobe, perihilar region, and superior basal segment of left lower lobe. The consolidation was extending towards the hilum and encasing the left descending pulmonary artery. There was also a solitary pretracheal lymph node on the left side, I believe, 16 by 10 mm, and there was enlarged subcarinal lymph node, which was 2 by 1.4 centimeters. So this is the case history, and I would ask our pulmonologist friends, a patient who is a 69-year-old reformed smoker with a history of cough and loss of appetite for 6 months. What would be your initial differential on this patient with the CT reporting which I have just called out?
Hello. Ma'am, because considering, sorry, if anyone wants to?
No, sir, you can go.
Okay. So considering age of 69, it's an elderly, more than 60 years, reformed smoker. So it's a risk factor for any malignancy, especially your lung malignancy, cough and decreased appetite. They all goes in favor of your any suspicious of any mass lesion or any lung malignancy. And there is a consolidation lesion, which is there in the left upper lobe and superior basal segment of left lower lobe. The catch point here, if you see in the CT scan, it is extending towards the hilum, and also along with there is a lymph nodes, which are in the subcarinal and the pretracheal. So whenever in this case, so if I would say the differential diagnosis, first would be to rule out malignancy. The second differential could be tuberculosis also, because we are living in an endemic country where there is a high possibility you can also have TB also.
Very rightly said, Dr. Prajay, because anything and everything can be tuberculosis in our country. But as rightly said, we don't have the films, but if we read through the description, it looks like there is consolidation which is not following the boundaries. And it is also encasing the descending pulmonary artery, which favors more towards the malignancy. Okay, so question open for everyone. How would you proceed on this case? I understand if we would have the imaging with us, it has been much easier to make a decision how we should proceed. But Dr. Gaurav, you want to add on something? How would you proceed in
Ma,
this case?
if patient would have had expectoration, we would have definitely
There's
Uh,
some problem with Dr. Gaurav's, I think so.
yeah. Dr. Gaurav, we're not able to hear you. Maybe some network problem. Prajay, you want to add on?
So, ma'am, in this case, as if you can go to just the previous slide, if you don't mind.
Mm-hmm.
So there was consolidation and the lymph nodes. So definitely, I would like to do a bronchoscopy
Yeah,
and with a backup in mind of keeping an EBUS as a backup.
right.
Because if I'm doing a bronchoscopy, I'll take a lavage and if possible, I'll try to do a biopsy of that lesion. Not because as we don't have the images per se, but it was mentioned that there is more towards the periphery. So there is a possibility we can do a transbronchial lung biopsy with a fluoroscope, or if there is a facility available of radial EBUS. And because of EBUS, we have to do a lymph node biopsy also. I think so Dr. Gaurav can take over now. So we can do a lymph node biopsy also so that if it turns out to be malignancy, we are good with the staging part also.
Dr. Gaurav, I think there's a problem with his network. Um, I would ask our oncologist friend, Dr. Chandrashekhar and Dr. Deepak, if this is the case scenario, how would you want us to do the, biopsy? What do you want from us?
Yeah,
So, but
good. Yeah, Dr.
go
Chandrasekhar.
ahead, Dr. Deepak. Go ahead, please.
Yeah, ma'am, good evening. So
Good
this patient looks like it has a tumor over the left upper lobe and left lower lobe, and also there are mediastinal node, that is subcarinal, and also the peritracheal lymph node. So definitely, what other doctors told that we will proceed with EBUS to make the definitive diagnosis whether that lymph node is positive for malignancy or not. But before that, if this whole picture looks means more like inclined towards the malignancy, I would like to go with first PET CT and followed by the EBUS and biopsy, transbronchial biopsy.
Dr. Chandrasekhar, you would like to add on that?
Yes, madam. Considering the age and smoking history, we have to rule out malignancy. And to rule out malignancy, I think if we have any lesion in lung upper lobe, then we can go for transthoracic biopsy of that lesion as well. And that should be followed by staging workup of PET scan. But it can be either way. You can go ahead with PET scan and then it can be followed by biopsy as well.
Okay. So if I'll just put up my this thing. If this patient would have been at CMC, what we would like to do is, because we would like to do an EBUS followed by and a biopsy as well, because at the same time there is no point subjecting the patient for another procedure. So do of the EBUS, you'll do an staging. At the same time, you do if there is an endobronchial lesion, bronchial, otherwise we would have gone to do a TBLB, and we send the all the samples for cultures as well, CBNAT cultures, as well as we will send for the histopathology examination as well. So this is PET CT. Our oncologist friend said about the PET CT. I understand, but probably at this point of time, we are keeping two differentials, though the malignancy is the highest differential. But probably for me, as a pulmonologist, I'm saying my first thing would be to get a diagnosis for the patient, and with one procedure in one go, probably get everything done. Okay, let's move on to so biopsy was done from the left lung, and Dr. Deepak, it was a CT guided biopsy, if I'm right?
Yeah, it was CT guided biopsy.
It was CT guided biopsy, and the biopsy was favoring non-small cell lung carcinoma, type being adenocarcinoma. So the patient's performance score was 1, echo was normal, and then the PET CT was done, which showed mild FDG avid ill-defined area of consolidation in left upper lobe, SUV of 3.4, then FDG avid right paratracheal lymph node with the SUV of 5.3. And there was a tiny lung nodule in a apical segment of the right upper lobe, which was non-FDG avid, and then another some sub-centimeter left lung nodule, non-FDG avid. So from the oncologist friends, where do we stand here? Maybe Dr. Chandrashekhar and then Dr. Deepak can put up their opinions.
Yes, madam. So this patient has multiple lung nodule, but these are subcentimetric and non-FDG avid. And apart from this patient doesn't have any distant metastasis. So it is difficult to comment whether this patient has stage 4 disease or not. And considering the paratracheal lymph node very small, it is difficult to do sampling of that lymph node. So I would like to treat this patient as stage 3 only
Okay.
as of now.
But this is paratracheal lymph node is FDG avid, and it is 1 centimeter. I think a pulmonologist friend will agree that 1 centimeter is very, very much, available for FNAC as well as for the biopsy.
Less than
Yes,
1 centimeter, we
yes.
can.
We can do
Yeah.
deeper
So
centimeter.
anything below 5 millimeter is said that, there is no point doing it. But anything above 5 millimeter, when we do for the staging specifically, we have to sample each of those nodes. So Dr. Deepak?
So, ma'am,
Okay.
just sorry,
Yeah.
can I?
Prajay wants to speak.
Yeah,
Yes, Prajay.
so sometimes the reporting by the radiologist also sometimes make a difference. But as if you can see in the PET scan and the CT scan was showing a subcanal lymph node of 2 centimeter. And your
Right.
PET scan is not showing. And sometimes even if it is non-FDG uptake, and if it's a 2 centimeter lymph node, we have to take a biopsy of the subcanal lymph node also.
Certainly. Agree completely. Yes. Dr. Deepak, you want to add on?
So this patient, the primary is certainly the T3 because it has a primary lesion of the left upper lobe, and also it is with left lower lobe also, and
Yes.
also here is a right paratracheal lymph node which is 1.1 centimeter. So definitely I will go with the paratracheal lymph node, whether it is positive or not. Determine the staging means it will definitely make a stage is that, and that will definitely guide us the exact management where we have to follow.
Right. So at least T3 and 2 we are sure. I mean, looking at that way, right?
Yeah.
I would ask Dr. Sukhram, are we operating T3 and 2 patients? 3B, I believe.
Yeah, ma'am, those patients may be, but there are two things I would like to make it here, because the first one is we have to first rule out N3 because it is showing the right paratracheal lymph node is there. So by EBUS we have to rule out that it's not N3.
Yes.
Now
Yes.
coming to the N2, at the PET scan I'm not looking at the N2 side. There is no node which is positive, but size is too big, I guess. So we have, even whether, and second thing is whether patient is fit for surgery or not, because minimum surgery will be in this patient may require the pneumonectomy. So I have to assess the fitness of the patient also. So the first we have to rule out the, N3, then N2, and possibly after N2, I would like to send patient for the neoadjuvant chemo. And if there is good response, and we may, post, chemo, we have to assess with the PET scan and then look at the fitness. If it's fit, then we may consider for pneumonectomy.
Yeah. So my question, Dr. Sukhram, was do we operate on T3 and 2 patients? Because the performance scale is 1, so seems to be a otherwise fit patient.
So still, I would like to have the opinion from, oncology perspective, because yes, ma'am, because there are so many molecules are there, and recently we have seen with the immunology and all those things, there is a complete resolution of the masses are there. So I would like to send the patient to the my friend medical oncologist.
Okay. So what are the further investigations you would like to do? Now we have adenocarcinoma. And the second question would be, is MRI brain indicated? And we said FNAC required for right, that we know that it is required. We have to do it. 1.1 centimeter is big one. And then what are the molecular testing you would like to advise? So open to all the oncologist friends.
Yeah, so definitely MRI brain, ma'am. Stage 3, stage 4, we do MRI brain with contrast. So that is must. Now coming to N2 disease, whether we can operate or not, it is difficult. For all practical purposes, we don't operate. Single station node less than 3 centimeter can be considered for surgery, but in clinical scenario, it is very difficult. So stage T3 N2 should be treated with CTRT. Once you consider disease is unresectable, then there is no point giving neoadjuvant therapy. We don't give. We go for definitive CTRT. Molecular testing, definitely EGFR, ALK, and PDL1. These three should be done on this patient.
The other thing is, just for my information, if you have a whole body PET CT done, is MRI brain going to add up anything on that?
Yes, ma'am. FDG PET is not sensitive for brain metastasis. So stage 3, stage 4, definitely you have to consider MRI brain.
Sure. And
I agree with the Dr. Chandrasekhar point. The incidence of occult brain metastasis in stage 3. This patient is stage T3 and 3 because it has right paratracheal lymph node. So
Yes.
almost occult brain mets is almost a rate of 20%, which could be missed on PET CT. So MRI is definitely indicated post 2B stage. MRI is the standard to be done. MRI with contrast in all the patient of lung carcinoma. The stage 1 you can avoid because the incidence is less than 1%. But as the stage increases, the incidence of occult brain mets increases. So brain MRI with contrast definitely. Molecular testing also, as Dr. Chandrasekhar mentioned, on the biopsy sample, we get to know the EGFR and PDL1. These both tests are required because that will also guide our adjuvant treatment. If I going for CTRT or if we are going for surgery, I think surgery is ruled out in this case because it has N3 disease. So surgery is ruled out. And EBUS FNSC for right paratracheal definitely because it will differentiate. Means mainly that it is N3 or N0 because it is a major differentiation in this case. Though we didn't done right EBUS in this case because there is a limitation in our city that EBUS is not available and patient is also not willing to go outside our city to get EBUS done. So I didn't get EBUS done. I consider right paratracheal lymph node as positive and move ahead for the treatment.
Yes. So in a scenario, I just wanted to ask, like Dr. Deepak said, that not at every place the facility is available. So in a scenario where is a FDG PET avid lymph node is there, the size is say 1.1, they are saying SUV of 5.4. Is it really necessary to do an FNAC or we can go ahead considering that as N3 disease?
I think if you ask the gold standard, it is definitely required to get EBUS done. But I think we have to select case-to-case basis regarding the resources and patient willingness and say finances. But if a good setup in a good corporate or in a where if EBUS is available, we should get it done.
No, 100% EBUS should be done, but in a scenario, we can still consider that because this is avid and it is big size, it can be still. How much is the difference? What is the difference in terms of if it is N2 or N3 disease? I do understand the survival difference is there, but does the treatment also vary?
No, if the patient is N2, T3 N2, then if the surgeon is willing to operate post neoadjuvant, then the management changes. But for radiation point of view, either it is N2 or N3 does not changes because volume is little changes in volume of our treatment field. Because nowadays we are doing conformal radiation, so there is a little bit difference. But major difference with the surgical point of view that whether this patient is going to undergo surgery or not.
Okay. Dr. Sukhram, want to add something?
Yeah, ma'am, because if it is N3, then the treatment surgery is out of question.
Out of question. Okay.
So then the main treatment part remains chemo, radiation, or chemo immunotherapy or radiation, whatever it is.
Right.
So if N3 is positive, then surgery is not helpful in this patient.
Sure. So this patient has all outside done and came to Dr. Deepak, where he has reviewed the slide, and molecular testing was not done. MRI brain was normal, and the impression final was T4N3M0 based on this thing. So the questions would be, I think we have discussed quite a bit of, so now we have a little more clarity. We don't have the molecular analysis on this patient, and we are saying it is T4N3M0. So how does it change the management? I know everybody wants to be very precise, and it should be actually. So the questions are on up. I'm not very thorough in oncology, so I just wanted to ask our oncologist friends, Deepak, Chandrashekhar, and Dr. Sukhram, to put up their views based on this. How would you treat this patient? Patient doesn't want to do molecular analysis, and this is all
Yes.
we have.
Yes, ma'am. So neoadjuvant option is out. We don't give neoadjuvant treatment in unresectable disease.
Okay.
Definitely, definite CTRT is the treatment to go for this patient. And ideally, at least EGFR and ALK should be tested for this patient. And if patient is not affording, then after CTRT, definitive CTRT, if we have good response, then consolidation immunotherapy.
Okay. Okay.
I agree with Dr. Chandrasekhar. We missed doing the molecular testing in this patient, but it should be done. And the optimal management in this case is radiation chemotherapy, concurrent CTRT, and followed by adjuvant either immunotherapy or adjuvant TKI, depending upon the molecular profile. And if nothing, no mutation is detected in molecular profile, then adjuvant immunotherapy in few cases or adjuvant chemotherapy. That Dr. Chandrasekhar can opine. But management is little same, that radiation chemotherapy followed by adjuvant systemic therapy.
Dr. Sukhram, you want to add on something?
And if it is N3 positive, then we should go for definitive chemoradiation. And if patient is affordable, we should consider the option of immunotherapy.
Right. So I think this.
But ma'am, I have one question here.
Yeah.
Looking at the CT report, there were a lot of tree in bird appearance and all those things were there. So should we rule out TB also, because with TB and chemotherapy, there is a mismatch of these two things. So how
I did saw that, but I was not very confident because we didn't had the imaging. I didn't wanted to put it up on that. And what Dr. Deepak highlighted, I just put it up on that. Yes, of course, we should be doing the bronchoscopy when we would have, if we would have done a bronchoscopy, it would have solved everything actually, rather than doing a CT guided biopsy. But I don't know, how was it? So this patient underwent chemo and sorry, Prajay.
Yeah, so ma'am, so that's only as a pulmonologist point of view. So whenever there's a malignancy, we know it clear cut, and whenever if you're taking a biopsy, especially of the lymph nodes, and if you're taking any lavage, you should always put the samples for the bacterial culture and gene expression TB culture, because sometimes some of the lymph nodes turn out to be necrotizing granuloma, and that time we regret that we have not sent for gene expression TB culture.
Agree, completely agree. So
I think your viewpoint is very nice. So Dr. Prajay, that we should follow the endobronchial biopsy, means lavage, and send for gene expert. So I think we don't follow because of the limitation in our center.
No. I was not for your case. In general, we were saying.
Also in general, because we as an oncologist look only the oncology. So as a pulmonologist, I think you might be thinking the other way, that you should go for this TB also and this other testing. But we don't see with those eyes, means looking for TB also. So I think your point is very well noted. That we should think in that point also.
So, one thing I would like to add, whenever you get, say, mediastinal lymph node, then invasive sampling is a must if patient doesn't have any metastatic disease. So whenever you get N2, until unless frank supraclavicular, only mediastinal lymph node, then the invasive sampling is a must. And in that thing, you can go for gene expert or whatever test it is.
So once we go out with the scope, it is there that you take everything which is possible. And so
Yes.
you come out with lots of sample, and once you're satisfied on the table, I appoint as a pulmonologist that you should have much of a sample that we can run everything out and we can make a diagnosis and we can clearly come out with some clear cut diagnosis what we have in hand. So we do not leave anything, we take everything which is possible.
Yeah, I think I agree on that. Living in an endemic country with tuberculosis, and despite lots of efforts by government that we will take off TB in, in 2025, which is gone, or 2035, which is world goal, it doesn't seems to be going. And as a rule, in our place, all the samples we subject for TB cultures as well, and there are lots and lots of surprises which comes out, malignancy and TB at the same time. So as Dr. Sukhram rightly pointed, if the patient is going for systemic chemotherapy, then the risk will increase if it is, there would be disseminated TB if it is not treated. So this patient completed his CTRT on 25th of August 23, and PET was done at the follow-up, where was a lesion in left lower lobe and adjoining left upper lobe with significant perilesional lymphangitis, and then FDG avid right paratracheal subcarinal. So this looks like they have increased in size. Earlier was 1.1, now it is 1.9 centimeter, and this was suggestive of some residual disease. Okay, we have something over here. That's a PET CT done at the follow-up after CTRT. Do you want me to run once again?
No, ma'am, that's fine.
That's fine. Paratracheal is pretty lighting up actually. Okay. So what is the next line of management? Do you consider we should rebiopsy for molecular testing now that patient has come to us? Previously, it was not done. And how should we proceed in this patient now?
So definitely, ma'am, this patient looks to have progression in lymph nodes in terms of size. So if it is increasing in size, then it is a progressive disease and it should be treated as stage 4 only. And in that case, definitely we need molecular testing to rule out biomarker-driven therapy. No lung cancer can be treated nowadays, and particularly non-small cell, without biomarker testing. So definitely molecular testing and either targeted therapies, or if biomarkers are negative, then chemotherapy plus immunotherapy.
Sure. Anyone wants to add on this?
I agree with Dr. Chandrasekhar that this patient either should be get rebiopsy done or molecular testing on the previous sample could be done, because this imaging is just 3 months post completion of CTRT. So, and since we didn't did the molecular testing before, we should get it done either with right paratracheal lymph node or from the primary. And surgery, I think, is this rule out because the patient is still in 3 disease. And PAL chemo observation we cannot keep. PAL chemo, yes, or we can think of giving adjuvant chemotherapy. So I question for Dr. Chandrasekhar that what will be your intent of treatment in this patient? Either it is a palliative setting or we will treat it as a definitive setting.
No, sir. So after CTRT, if the patient has progression in any site like primary or nodal, then the intent of treatment is not curative. You can give, after CTRT, it is a bit difficult to give SBRT or those sort of thing. It is not possible to give immediately. So you cannot irradiate nodal area with high dose of radiation. So in that case, either biomarker-driven therapy. If biomarkers are negative, then second line of chemotherapy plus immunotherapy.
Okay. Over to ma'am.
Okay, sure. So I think this is finished. The takeaway from this case would be, from a pulmonologist view, I think we should aim for investigation or diagnostic modality, which will try to put up everything together. So if I would, when I'm looking at the CT, I think the last PET CT, I think EBUS with the BAL TBLB, bronchoscopy BAL TBLB would have been a better choice for this patient, which has given us the entire thing. Have ruled out the possibility of tuberculosis because there were mention of some tree in bud appearance, and then we would have sampled the lymph node as well. The other thing is that if you are having adenocarcinoma, that mandatorily, before even sending to the oncologist friend on the sample, please ask for at least 3 molecular testing. What you need to do is the ALK mutations, the PDL1 and EGFR analysis. You send it on the sample and send it to your friend also. By the time patient reaches to oncologist, I hope these things will be ready. Then while we are treating, it becomes really difficult to treat the patients with cancer with limited information available, as we know that we have now very targeted therapies. So we should try our patients to get convinced to get the minimum molecular testing done so that a targeted therapy can be given to the patient. So we'll just, anybody wants to add on before I finish off this case and go on to another one?
You correctly summarized, ma'am. Correctly, yeah, right. I agree with your points.
Sure.
Nicely summarized, ma'am. There was just one query to the oncologist because they said that the molecular testing could have been done on the previous sample.
Mm-hmm.
So just wanted to know whether they're doing it on the previous sample or doing it on the fresh biopsy sample. Does it make a difference or is it the same way?
Yes. So once there are two things. Once disease-free interval is very long, like 2 years, 3 years. After that, if patient is having recurrence, then there might be some acquired resistance mechanisms in that patient. But this patient has very short disease-free interval, so it doesn't matter whether you will go for testing on primary or after, I mean, progression on nodal sample. So for this case, it doesn't matter. But yes, you are right. Once patient is on treatment and having disease-free interval of say 2 years, 3 years, 4 years, then definitely it should be done on newer sample.
Sure. So I think we had a very good discussion on case 1. We'll just move on to case 2, which has been shared by Dr. Gaurav Sahu. I'm just speaking on behalf of him. He's a 64-year-old male farmer with 50-pack-year history of smoking, presented to hospital with progressive dyspnea, MMRC grade 1 to 3 over 2 months, cough with scanty sputum 1 month, low-grade fever, anorexia, and weight loss over 1 month. And there's a history of CVA in 2017, which was managed medically. Journal examination, vitals were stable, but he was saturating 90% on Rumia. Mild pedal edema and clubbing was present. And on respiratory system examination, there were features of left-sided pleural effusion and the collapse. And we have the imaging here. So this was the chest X-ray of the patient. So do we agree on that there seems to be a homogeneous opacity on the left side of the lung, but there is no shift of the mediastinum. So unless there are features of effusion on examination, which is stony dull node, or an ultrasound which will suggest there is an effusion, probably I would consider this as a collapse only. Other pulmonologist friends can add on this.
So, ma'am, we did a USG of this patient and we could find that there was a effusion, and as a normal effusion which comes in our OPD, but he had a 90s room air saturation, so we admitted this patient.
Right.
And he's so we had to admit this patient, and when we saw it was a large massive effusion. So patient was also desaturating. So we did a diagnostic tap, and after all the precautions, we put an ICD in this patient, and we could see a hemorrhagic fluid coming out from this patient. And it was in large volume. Patient was also relieved by it. So even though mediastinal shift was not there very much, so we could suspect that it can be mesothelioma. Although the occupation was farmer, he was not subject to any other asbestosis like occupational that thing. So the next slide. can have, ma'am.
Yeah. So if I just talk about this X-ray only, and an ultrasound screening in showing me pleural effusion, which is the first line of investigation for us, any patient we do an ultrasound, I would have rather, we would have been diagnostic aspiration, whatever the diagnostic aspiration is. If suppose diagnostic aspiration is negative, would you straightforward go for the medical thoracoscopy or a closed pleural biopsy? Or you would like to do a CT scan for this patient?
We'll get a CT. We'll get a CT. So
Yeah.
contrast
Yes.
CT was done.
Yeah. There is no shift of the mediastinum, and that is something which is worrying me a lot, whether there is some endobronchial lesion which is causing the collapse. So effusion with collapse is there, or this is consolidation. I don't know. But anyways, so we had a CT done. And the CT on the left is from 7th of October, which is an HR lung window we are seeing. And then CT on the right side of the screen is on from 17th October. So I'll just run through this CT scan, which shows significant amount of pneumomediastinum. And there is left side pneumothorax as well. Significant paraseptal emphysema is there. Lots of emphysema is there. And we could see a chest drain as well, chest tube going in. Some areas of ground glassing and probably on the left side. And then there is a collapsed lung with effusion. I'm not very sure. Some effusion is there. Okay. So do you want to add on? Anyone want to comment on this?
So, ma'am, this was May patient only. I'll go through. So, as the patient came, he was very sick. We had to his PCO2 was some around 100 or something. We had to manage on an IEP. So first we have to see the status of the patient because we could not perform anything else apart from doing an ICD.
Right.
And he was coughing too much, so he had this pneumomediastinum and pneumothorax, and eventually the patient was pharma background and admitted under Ayushman, and there are a lot of things we cannot do in that Ayushman thing, and we need some time. That coding and all is there. Then we managed the patient. His ECOG has improved a bit, and then we could plan that we could subject him for thoracoscopy after correction and stabilizing the patient over a time. So that is what we did.
No, I agree completely. If the patient is not fit, we should not be jumping on the patient and doing of the procedure because we want to do it. Patient has to be stabilized first, and with this pneumomediastinum and other things, certainly. So it looks like there was rupture of some of the emphysematous bulla. Patient was on BiPAP therapy, and probably that was the reason. So chest drain was okay. So this is the CT scan on 17th of October, which I believe everything has resolved. Clinically, patient is kind of a bit stable now. And this shows effusion. There is something on the right side also. I would prefer to have a lung window, but okay. Is it something in the kidneys as well? I don't know.
No, ma'am. CT abdomen
was just a cyst only. There is something over here. Maybe it's just a simple cyst. If we could, you can see on the
CT abdomen was completely normal, and there was nothing in abdomen.
This kidney on the
not a metastasis from my point of view. Cyst.
Maybe just a simple cyst. Okay. So, how would our pulmonologist friend, Gaurav has done, so I would ask Prajay, what do you think about this patient and what do you want to do it now? Patient is stable.
Stable. We have sent the pleural fluid for the analysis. So we will wait for that reports.
Right.
And because once if the reports are available, I think so we have not shown the reports, right? If I'm not wrong.
Yes. We will go ahead and, this is I'm sorry. So the hospital cause he has already mentioned. So while ICD was done, the pleural fluid was collected and it was sent for analysis, and patient, because had type 2 respiratory failure and sputum has grown some Acinetobacter, he was managed, and that's one. After 10 days, a CT was repeated. So this is the laboratory findings. Blood investigations were normal. It was an hemorrhagic fluid with the counts were not too much, 220, maybe because RBCs were so much they were not able to see it. It was lymphocytic predominant with the LDH of 874 and ADA of 22. Cytology was negative. CB NAT was done, which was negative.
So so there are certain two reports which are there down.
Yeah,
It shows. Sorry, because if we go through that. So if we see the report, first thing is hemorrhagic when it is always a catch.
Right.
Unless if your ADA levels are high, then it is always we have to suspect a malignancy. Unless and until you prove it that it's not malignancy. If your ADA levels are high and if your suspicion is also TB, you can get hemorrhagic with tuberculosis also, or can we get with some connective tissue disorders. So now in this patient, because of lymphocyte predominant, exudative, but ADA normal, and cytology being negative, I feel my personal experience, I don't know about others, most of the times the cytology comes negative, and then we have to go for the pleural biopsy, as you have done in this case, the thoracoscopy wise. But now, as if we are going through the downwise, the gene expert was negative. Madam will add the LPA test was done, and which shows it was TB detected and isoniazid resistant. So, if sorry, you want to add?
Prajal,
Yeah, sure.
So NAT was negative. It was a routine procedure. So what we do, we take a sample and we send it for culture also. So this is a routine work we do. So even when the report came after 1 week, because LPA would take time in government sector. So when the report came, we were even surprised. So because
the government at your place is very nice. Even if your gene expert is negative, they are doing LPA. But for us,
I'm in a corporate setup, so this was sent as in a government setup because culture is done in a government setup. So they sent it to
if you
IRL.
ask in Mumbai, the culture is like if the gene expert is negative, we don't put it for LPA. That is what we do it here. I don't know about madam what she does at Vellore.
No, I agree completely. We don't do LPAs. The thing is, if we are looking at something that we are suspecting TB or anything, then pleural biopsy is a better sample to send for CB-NET or for culture as well. So I was also surprised, and I asked the same question, Gaurav, how did you do an LPA for the patient? Because if NAT is negative, we send, as I said, it's a practice. We send all the cultures, biopsy as well as pleural fluid for CB-NET and for the midget cultures. We don't send for LPA. In our microbiology, actually, if CB-NET is showing low positive or this thing, they don't do LPA. They say we will wait for the cultures to grow and from there we will do an LPA, something like that. I don't know how
in our requisition form, what we do, we write a LPA/midget. So they send it and they prepare a smear. And even we were surprised that NAT did not detect it. But although it came out to be positive in LPA, so then I rechecked it again. Is it culture? But it came in just a week. So that was a surprise to me too, because this usually does not happen with all of us. And then I was waiting for a biopsy. And the next day the biopsy comes, and what we were expecting actually was in biopsy, that it is a malignancy, but this came as a gift, and it was a very surprising thing for us, and that too resistant, mono-H resistant. So then I looked for genes. So it was CATG gene and INHA, both were resistant. So we could not deny it. Yeah.
No, I agree completely, because actually, if any of the genotypic test is coming positive on samples like pleural fluid or CSF, the specificity is very high, though the sensitivity is very low. Sensitivity for LPA would be for pleural fluid maybe somewhere between 4%, 6%, less than 10% if I'm right, and same is for CB-NAT. So just wanted to ask Gaurav, what did the midget culture show?
Midget culture, ma'am, we did not get that report.
Oh, okay, okay. And in this scenario, because you have got INH resistant tubercular pleural effusion, INH resistance, did you ask for second line LPA as well? Because now we would be, instead of INH, forget about the malignancy at the moment, but INH resistant, you will be giving R, L, E, and Z.
Right.
So in that case, it becomes important to send for second line LPA to look at whether FQ resistance is there or not. I think Gaurav got freezed
Network
again.
freeze.
Okay, so now let's
So, ma'am, just a question here. As you rightly said, we'll have to do a second line LPA.
Hello. Am
Yeah.
I audible?
Yeah.
Who's this?
So,
Sorry.
Dr. Gaurav, you were.
Yeah, please, Gaurav, please tell us.
No, ma'am.
You're
Actually, my
audible.
net got disconnected.
You're
Yeah.
audible, very much audible.
So, ma'am, Mitchell did not come. We asked him to get the. So they said, yeah, LP is positive, and then government people they did not do a visit for it. Very good.
Ma'am, can I just ask a simple thing here?
Yes.
Like if your ADA report is normal, and everything is there, and if the LPA was not there, we would have definitely gone with a thoracoscopy to prove it. But if ADA would have been like around 50 or 60, would you still go with the thoracoscopy or give a trial of AKT and observe this patient just as a.
Okay, so Prajay, if you are asking me, my views are totally different, and I do not believe ADAs. It is for the reasons, though we have meta-analysis, we have systemic reviews, and everybody is saying that, ADA bit above 40 and 70 TB should be taken. But at CMC, we do not, somehow, the way they do ADA, we are not happy with it. So our patient, even if ADA is, in the range of 40 or 45s, but CBNet is negative, cytology is negative, cultures are negative. So we do subject the patient for thoracoscopy. We don't give them empirical ATT. So we confirm the diagnosis and then only we give. I'm sure lots of people will not agree with me on that, but we do not follow ADA. Gaurav.
So, ma'am, at our centers, what we are doing, if patient is young and is not a smoker, and the history catches the diagnosis towards tuberculosis, we will give him an option that we can do a thoracoscopy, and if you want a confirmatory diagnosis, so that should be patient's choice. I think if he wants, he's young, he's not a smoker. But if it is he's smoker and he's more than 50, I guess 45, then definitely we should post him for medical thoracoscopy, and there are good results and patient benefits a lot.
I agree completely. If the pre-test probability is a young patient and history is suggestive, then take an ADA and start off the treatment. It's very well, established, and there is no harm in doing that. It's just that, I won't be discussing this on the national forum because I understand every institute has their own practice, which is different. But we have seen quite a bit of young malignancies, very, very young patients who have come as malignancy. And we have also seen lots of, I won't say lots means 20 or 30%, but at least 5 to 6% of pleural TB coming as resistant TB. And we ourselves has published the paper where we said that if you give the pleural biopsy and send for CBNet or cultures, the sensitivity increases from 10% to 45% and 50%. So that's the reason I believe, but I agree, Gaurav, completely. Young patient, pre-test probability is TB, ADA is 40 and above. Yes, you are very, very much right to start that patient on TB treatment.
Only thing we'd like to add here, in this patient, it was an hemorrhagic fluid. So if it would have been a straw colored, I would, in my case only, I would say, I would definitely, like example, if AD would have been high, I would have started. But when it's still for the audience, I would say, if it's an hemorrhagic, you have to be very careful. Even if you're starting AKT, it could be malignancy still.
So our first diagnosis was definitely a malignancy in a reformed smoker. This just came up to us, and even we were a bit concerned that it is a false report. But then patient had fever, and he took a treatment for this moonlight resistant, and in the later course he has improved. But then we had a challenges with medical oncologist, and now I think our oncology friend should put a light on it that Should
Yeah.
we have gone with concurrent?
So that's the question I would, because we do have patients who have concurrent TB infection as well. So we want to ask both our oncologist friends that if this is the situation where you have dual pathology, do you want to start off the concurrent chemotherapy or your treatment for malignancy at the same time? Or do you want to give 2 weeks of ATT followed by, what is the protocol?
Yeah, so, ma'am, in our practice, what we follow, if patient has concurrent tuberculosis, then I tend to give 4 weeks of ATT.
Okay.
Then only I start chemotherapy, which
Okay.
is myelosuppressive. But
Right.
if you are going for TKIs like EGFR or ALK-driven therapies, then it can be started on day one as well. These
Okay.
drugs doesn't interfere too much. But yes, with anti-tubercular drugs, you have to be aware of drug interactions which are there, and we have to take care of those things.
So if it is TKIs or biologicals, then you can start on day one. But if it is something else, some other chemotherapy,
Right.
immunosuppressive therapy you are giving, then you would like to wait for 4 weeks at least before you start
Yes.
the treatment.
Yes, ma'am.
Is
Yes.
it what Gaurav also, Dr. Chandrashekhar
Deepak.
also say?
Yeah, this is Dr. Chandrashekhar only. Dr. Deepak
Oh,
will
I'm
add.
so sorry. I'm getting confused, doctor, because I could not
Yeah,
see your faces. So Dr. Deepak also follows the same thing?
I think I also follow the same thing, and this case is really very nice
Yeah.
and very well investigated. So this case really means put the focus on what is the benefit of multidisciplinary approach. Had this patient would come to the oncologist, he would definitely think of a pleural fluid as a malignant effusion and go on with that, because if the patient have received to be the, by the pulmonologist, they have done a lot of battery of tests with all NAT, LPA, and medical thoracoscopy. So make a definitive diagnosis that this patient has malignancy along with the a malignant effusion, means a pleural effusion that is isoniazid resistant. So very nice. I think I'm very happy with this case. But you mean this means thorough investigated. So what is my point? I am a radiation oncologist. Radiation point of view, there is no contraindication to start radiation in a patient who is on AKT start. But the definitive management of lung cancer is concurrent chemoradiation. Since we have to delay the chemotherapy for 4 weeks because of the AKT, so I will definitely also start radiation after 4 weeks because it has to go simultaneously. We don't practice, means there is no recommendation of giving a TKI along with radiation therapy. It is not standard of care. So TKI, suppose it is palliative intent, then that can be done. But in the concurrent setting, TKI with radiation is not done. So definitely I will go with Dr. Chandrasekhar point. We will wait by 4 weeks to start radiation also and along with chemotherapy.
I think so. It's been very well summarized that it demonstrates the rare coexistence of lung adenocarcinoma and NH-resistant TB fusion. Negative pleural fluid cytology emphasizes that malignancy cannot be excluded without tissue biopsy, underscoring the importance of biopsy. Then comprehensive microbiological testing, including LPA, is essential to detect drug-resistant TB, especially after TrueNet was negative. Some reservations about this, Gaurav, because probably cultures would be the better way. And then radiological overlap can be there. You can have similar kind of pattern, nodular pleural thickening, subpleural nodules in malignancy as well as TB.
I completely agree.
Early
But
recognition is very, very important. And having an MDT with your oncologist friend makes life easy, and we know where we are. We can give a definitive plan to the patient. See, you have to take ATT for now 4 weeks, and after that, Dr. Deepak and Dr. Chandrashekhar will take over for further treatment. So anybody wants to add on this before I finish and we move on to the surgical cases?
ma'am, one more thing. Malignancy itself is an immunosuppressive condition, right?
Yeah.
So patient could have got the tuberculosis from his distant relative and all. But when we asked the patient for the history, he specifically was adamant on just for 2 months he had shortness of breath. I think it would have been an extensive
Yeah, longer history rather
lobular
than
and paraseptal
patient was.
emphysema. He would have been a shortness. He had shortness of breath, a long history. But he was denying to the fact that he was completely all right 2 months back, and that is something which was not adding up.
Yeah, I think I agree with you. Sometimes patients, especially elderly patients, what happen is most of their symptoms they attribute to the aging. And only when they become more symptomatic is the time when they say, okay, now it is going out of control. That is when they start realizing that something else is going on. So this is very, very important, especially in a patient who is elderly, who is uh, a smoker, current smoker, is a 50 pack years. I would rather not, just understand that. I would go ahead and do a everything possible. CT scan is also showing emphysema. So certainly this patient is a poor perceiver for his symptoms. And history is, I mean, our teachers have told history is something which can give you the clinch of the diagnosis, but at times we have to be a little more prudent, taking into account all other factors while we are deciding what would be the best modality of diagnosis. And we should not just stick, if there is anything clicking, something is not fitting into it, please go ahead, listen to your senses, and go ahead and do further testing.
Then we had a catch also in this case. He had clubbing, and he had
Yes. And in COPD, we don't get clubbing. In
had
TB, we
clubbing.
don't get
So
clubbing.
he
And
had clubbing.
yes, so that is certainly a really good case. So somebody wants to add on something?
Yes, ma'am. So I would completely agree with you. I have patients who are in their 20s, like 25, 26, and they have ALK positive or EGFR positive adenocarcinoma. I
Yes.
have few female patients who are non-smoker, very, very young. And these patients can have malignancy. So definitely we have to keep in mind. One thing I would like to ask all of you, ma'am. So what amount of pleural fluid should we send for cytology? As Dr. Prajay told, most of the time we get negative cytology report only. But what is your clinical practice? What amount of fluid you send for cytological analysis?
Minimal 30 ml. So 30 to 50 ml is something an optimal amount. And sending repeated samples does not add on to the diagnostic yield, actually. So between 30 to
And
50 ml is something which is what we do.
and sir,
Okay.
if nowadays if patient is not willing for any invasive procedure, we have cell blocks also. Now many pathologists are preparing cell blocks, so we can get
Yes, yes,
if a
yes. We routinely do. We always send pleural fluid cytology and cell block for malignant cells.
Ma'am, is there, sorry, during our residency days, we were taught that the pleural fluid, when we are sending for a cytology, because it is used to go from a government setup to some different tertiary care. So we used to just heparinize the wall of the containers.
Is
So
it?
does it, because it was said to preserve the cell structures and it should not. So does it should be done it, or how it should be exactly?
Uh,
Now in our hospitals, we send it directly, it goes in the laboratory, they make the blocks. But if there is going to be a time gap or something, should we do that thing?
No, Prajay, we don't do that. And I'm sorry, I'm not aware of this thing. Probably I would rather read this, but we haven't practiced. We don't practice. And as you said, the sample goes immediately, or say in 2 hours or 3 hours. It doesn't have to wait. But other friends, if they want to add, do we? If is there a practice? If the patient sample is sent a little longer, should we heparinize that? I have no idea.
Heparinize means just the walls of
Just
the country. Yeah, just
walls of that thing.
rinse it kind of a thing.
I'm not aware of that. Maybe I need to do a reading on that.
but definitely if you heparinize, we cannot make a cell block. That is one thing. So
True,
they
true.
Okay.
so
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 that's
we
a
do
new
not
thing which I
heparinize.
also got to know.
So if you heparinize, you pathologist will never make a cell block.
Okay.
Okay, so
So
we
I
sorry.
have a one or two questions from you panelist. So this does this patient fit in MDR means multi-drug resistant tuberculosis, and what is the course of treatment in this patient? How do you treat? And suppose this
Sir,
patient went to oncologist and is on chemotherapy. So do you alter your tuberculosis drug or do you extend the duration or something? So throw some light because we want to know regarding your
sir,
management of this case.
that was mono-H resistant, and so we had a clear-cut guidelines to follow ERZ levo. Earlier, we used to have kanamycin in it, so that was removed. So injectables we are not using. it is ERZ levo which we have to use, and that is a standard protocol treatment which we have to give unless and until some side effects are there and we have to change the regimen. That's it.
For how many months do you give the AQT this patient?
I'll add on, Dr. Deepak. So one thing, this is not MDR. MDR tuberculosis is set when there is a resistance to either rifampicin or rifampicin and INH. So this is INH monoresistance treatment. And when this happens, you just omit INH, and instead of INH, you add levofloxacin to the existing RHEZ thing. The treatment goes for 6 months, and depending on to 9 months. 6 months to 9 months is the treatment, depending on how the patient is doing. Certainly, if there is some interaction with the drugs, then we might have to consider. Otherwise, RLEZ goes for 6 months together.
Okay, thank you.
So we move on to 3 small case scenarios, which has been shared by Dr. Sukhram, who is our CTBS surgeon from Medanta. We look at this first case is a 72-year-old gentleman, cough for 3 months, is a smoker, chest X-ray revealed left lower zone haziness, and PET CT was showing fibrocavitary lesion with an SUV of 23.6, and it was intending the fibrocavitary lesion in the left lower lobe, indenting costal pleura. There was varied tracer uptake in bilateral hilar and few mediastinal lymph nodes as well. And I'm sorry, one second. This is the CD scan. So I would ask the panelist here, we could see there was multiple lymph nodes. There is a cavitatory peripheral lesion in the left lower lobe. And if I could see quickly, it was an eccentric cavitation. And then there is lots of emphysema as well. So this patient, EBUS was done, and CT guided biopsy was done. EBUS was negative for malignancy in N2, N3 station, but gene expert was positive. CT guided biopsy showed a squamous cell carcinoma. Staging wise, it was T2, N0, M0. So how would we proceed in this patient? We'll ask Dr. Sukhram because it is T2, N0, M0, his case only, but I would rather ask the pulmonologist friends and other oncologists, and then Dr. Sukhram will add on. Gaurav, you are muted. Yeah.
Yeah, I have a question. That gene expert was positive in BAL or just EBUS guided FNE or the CT guided biopsy taken from the lesion where it was positive?
Positive in EBUS, lymph node was positive.
Lymph node was positive. Okay.
So now one more question to you only on the gene expert, whether it was MTB detected low, medium, high, or it was MTB detected trace. Because if it turns out to be trace and indeterminate, then it can be a false positive.
False positive.
So it's medium, it's not trace. It was medium.
So that cannot be neglected is what we are trying to say.
Because
Okay,
why this question was told, I asked it because most of the times we got a reference or something if it's a malignancy that the patient also has a TB. And when we
Right.
go and ask the microbiologist to give us the second page, then so it turns out to be trace and rifampicin indeterminate. So that
Right.
gives you a false positive. And in that case, we have to be very guarded while whether we have to treat with AKT or it's just a malignancy.
True. The oncologist friends, they would like to have anything you would. I'm just wondering, is this squamous cell carcinoma? It is a peripheral tumor, right? Usually squamous cell carcinoma are the central tumors. Dr. Deepak, Dr. Chandrasekhar?
Yeah, ma'am, it is, I think, T2N0M0 and gene expert positive for the lymph node. So I think the surgeon will take care of this, go for surgery. PET-CT has already been done.
Okay.
And
So let's ask Dr. Sukhram, what did he plan for the patient?
So, ma'am, we did VATS lower lobectomy with the systemic mediation lymph node dissection, which include the all lymph node on the left side. And before that, we had brain MRI and the fitness of the patient in the terms of cardiac as well as physical fitness, which we do on the basically PFT, DLCO, and stair climbing and all those things. We assess the fitness in that term. And patient seems to be fit and good surgical candidate. So we went in and did the VATS lobectomy with the SMLT, and the final biopsy was squamous cell carcinoma, and it was T2, and no lymph node was positive in this. For malignancy.
Right. So pre-surgery and post-surgery, both staging was matching T2N0. And did the lymph node was subjected for cultures, midget cultures or CB-NAT again?
We didn't send for the culture, ma'am, but yeah, sent for biopsy, which was granulomatous.
It came as granulomatous. So that is what
Yes,
the problem is, Dr. Sukhram. Sorry to be a little blunt over here, but that is the same problem with the surgeons. They just cut. I have been, even here we find it difficult. We ask them that please send the cultures also, but many a times the cultures are not sent because gene expert was positive. I would be very happy if the lymph node would have been sent for midget culture as well. And we look forward whether, it is a susceptible or a resistant TB. So in these kind of a patient who have been resected, it is T2, what is the follow-up you do and for how many years the patient should be followed up?
I sent, though here after the biopsy report, we sent patient for the medical oncologist.
Okay.
So they have their this thing because it's a T2. So anything beyond T1, A or B, nowadays there are guidelines which says we should do some sort of molecule if it is available or some sort of chemotherapy. If it is there, then we should consider that. So we sent patient for the med onco review. So they will be better to answer.
Okay.
So
Yes,
ma'am. So anything above 1B nowadays we give adjuvant chemotherapy for sure for 4 cycles. Platinum-based chemotherapy. If it is squamous cell, then paclitaxel with carboplatin or cisplatin. And in squamous histology, usually we don't get biomarker positive EGFR, but yes, PDL1 we frequently get. And if it is positive, then immunotherapy after 4 cycles of chemotherapy.
Okay. And how do you follow up these patients?
Ma'am, I have one question.
Please, Gaurav.
Ma'am, sir initially told in my case that they give 4 weeks of ATT and then wait. If it was T0N0M0, would they wait for that much for time or straight away?
Yeah, so
Yes. So in this case, definitely, anyway, after surgery, you are giving 4 weeks to patient before starting any sort of adjuvant chemotherapy. You have to give at least 3 weeks. So that time ATT can be started immediately after surgery if it is positive.
Sir did upfront surgery before giving ATT, or this ATT was started simultaneously?
Dr. Sukhram?
Yeah, ma'am. We started as soon as we had EBUS and EBUS was positive. We started on ATT, but we went ahead with the surgery. We continued in the post-operative period.
Because it was not an open case, I believe it was non-infective only in lymph node. It was a wise decision. But if Dr. Sukhram, this would have been kind of a sputum or a BAL positive, suppose I'm just, then do you wait for those patients for the surgery or you do off?
No point of operating patient in the open case.
So you would wait for 2 weeks or 4 weeks?
At least it should be negative in any format by the bronchoscopy or the sputum. So
Okay.
AFB should be negative. I'm not worried about gene expert. When gene
Yeah,
expert
yeah,
in our
certainly.
case scenario, at least we have the post-operative lymph node biopsies. They are 20%. They are positive, so we see it in the lymph node frequently.
Yeah,
But I'm not into the AFB should be negative.
sure. Okay. So that's
So, ma'am, as you asked this question, so just a question for everyone. So as you said, he said ki the AFB should be negative. Like example, if BAL turns positive, you start AKT. Do we actually do a repeat bronch after 2 weeks, or we can assume it because they said ki 95 more than 95% of the bacilli gets killed within a period of 1 week after starting AKT. So then after 2 weeks, can we definitely go ahead with the surgery, or we repeat a BAL and prove it that it's AFB smear negative?
So first is sputum. If sputum is negative, it should be bronchoscopically proven that the BAL is negative for AFB, and then should be considered for the surgery.
Okay, so our surgeons are not very strict in that way, Dr. Sukhram. They will take for 2 weeks because it is considered susceptible TB. Usually they are sputum negative by 2 weeks. So we don't wait, we just send the induced sputum. We don't subject the patient for repeat BAL because, lots of things associated with this. The money goes, then patient may not be willing. And sputum negative, smear negative, they take up the patient. Okay.
One thing I would like to add, ma'am,
Yes.
if you have T2 disease upfront,
Mm,
then nowadays we have data for neoadjuvant chemotherapy
right.
with immunotherapy.
Yeah.
So any tumor above 4 centimeter, we don't treat straight away with surgery nowadays. We do give neoadjuvant chemo immuno. We have strong data of nivolumab with chemotherapy.
Okay. And if they are improving,
Yeah, yeah. So after 2 cycles of chemoimmunotherapy, you can take those patients for surgery.
acha, so that has a better outcome, is what you are trying.
Yes, yes,
Oh,
definitely.
okay. So now this patient, how would you follow up? Because Dr. Sukhram has operated and he has given over to you. Surgery is done. Patient has received, you would say that you will give some chemotherapy followed by immunotherapy. How long do you follow these patients?
Yes, so minimum follow-up period is 5 years. You have to give 4 cycles of chemotherapy and 1 year of adjuvant immunotherapy to all
Okay.
patients. And after that, we follow up patients for 3 monthly for 2 years, then 6 monthly for 5 years.
And these follow-ups, does they involve what kind of imaging? Do you do PET-CT every time, or is just a chest X-ray, or how do you follow up?
No, we try to do imaging once every 6 months at least for all CA lung patients.
Right.
But it depends on symptoms also. If patient is symptomatic in between, then you
You
have
can
to perform
always do it.
imaging. Yes.
Sure, sure. Agree, agree. Anyone wants to say anything? Otherwise, we'll move on to other case shared by Dr. Sukhram. No? Okay. So this is a 71-year-old gentleman who has cough and hemoptysis for 1 month. CT was suggestive of right suprahilar mass. He is also a diabetic, hypertensive, and on a PCI for AV block. PET-CT was done, which shows a right lung mass with an SUV of 11, and the mass is 4.8 by 4.4 into 5.8. And FTG evid subcentremic right lower paratracheal subcarinal and bilateral hilar lymph nodes with SUV of 4.91. Now that's interesting. This is imaging. Okay, let's move on to, so this patient, as we could see, there was a hilar mass, and I'm sorry, something is, hmm. uh, and we could see that there was a bronchus cutoff was there. Bronchoscopy shows infiltration into right main bronchus, poorly differentiated as squamous cell carcinoma. EBUS FNAC was done, and 7 and 10 station lymph nodes were negative, but 4R was positive. So staging was T3 and 2. How would you proceed with this patient? Dr. Chandrashekhar, Dr.
Yes. Yes, ma'am. So all practical for all clinical scenarios like this, we go for we try to treat this patient as unresectable disease. T3 and 2. It is difficult. I think it is already operated or what, ma'am? It is
That
written
Dr.
P.
Sukhram will tell us.
Oh, okay. So it is written PT3 and 2. I don't know whether it is already operated or what. So usually clinical CT3 and 2 we don't consider as resectable disease nowadays. We have to give go for definitive CTRT.
Okay, so this patient underwent
So
immunotherapy.
I have a point. So T3 and 2, yeah, definitely. If you go with the guideline, these patients are, I think, depends upon the multidisciplinary team that whether patient is resectable or not. If the surgeon finds it is resectable upfront, means they can go for upfront surgery or after giving a neoadjuvant chemotherapy. But if the patient is cannot be operated even after giving neoadjuvant chemotherapy or upfront or because of cardiac morbidity, then definitive CTRT followed by immunotherapy is a standard care in this patient. So
Okay.
that totally depend upon the surgeon pursuit that whether they want to operate or not. But N2 is not a means it is a relative contraindication means or partial you can say means 50-50 that it could be done either surgery you can go
So,
both.
sir, they tell that you have to follow very stringent criteria, like nodal station should be single, it should be less than 3 centimeter. Then only you can go ahead with the resectable approach.
This patient has only single station 4R, and I think the lymph node size was also small.
Yes,
If you
sub-centimeter. They were
sub-centimeter.
sub-centimeter.
Yeah,
Yeah.
yeah,
So, if I get from the very first what we were discussing the case, the discussion went in like that. If it is T3 and 2, then usually a new adjuvant therapy followed by surgery. That is what my takeaway was from there. So, is it what Dr. Sukhram, you also have to say on that?
Yeah, ma'am. And see, N1 is completely surgical case. N3, its surgery is out of question. Now,
Right.
there is a, debatable issue in N2. If it is single station, a smaller lymph node, and your surgeon is comfortable to operate, as in this case, we were, able to take out the R0 resection.
Okay.
So it's single station, then we can consider for the surgical candidate. If multi-stations, bulky lymph node, disease is very heavy, then we nowadays in current scenario, we ask them for the NACT immunotherapy with chemotherapy. If that is there, then many of patients who are actually having the bulky disease, the disease reduction is significant. Few of them are having the complete response, few has the partial response. And in that case scenario, we can consider for the surgery.
Right. So in this patient, based on the MDT discussion, tumor board discussion, new adjuvant chemotherapy was given and repeat PET was done after 3 cycles, which actually showed partial response only. So then, Dr. Sukhram, you can add on your side.
So, ma'am, as we were, this patient has good response with the chemo and immunotherapy. So when we did repeat PET scan, we were sure of that we will be able to take it down the R0 resection. So in this case scenario, we did the sleeve lobectomy because the upper lobe bronchus was involved. So we took the good margin, sent for frozen intraoperatively, frozen was negative. So we anastomosis the bronchus intermedius to the main trachea. And there we are now, it's a complete margin negative, and all lymph nodes were negative. We took out roughly around 24 lymph nodes, and all were negative. Margin was negative. So in a sense, it was a R0 resection.
Wow.
And then we sent for the whole. Everything was sent for the NGS, and our friend has given. They can explain better
Yeah.
what these things are.
The oncologist friends, please come on this. So this is the plan given by the team in Medanta. Do you agree on that?
Yes, completely. So you have to test for basically three markers: EGFR, ALK, and PDL1. If EGFR or ALK is positive, then you have to give targeted therapy after 4 cycles of adjuvant chemotherapy. If these tests anyway, by the way, you have to do upfront before deciding any sort of treatment, not after surgery. So if EGFR and ALK both are negative, then you have given chemotherapy plus immunotherapy as neoadjuvant treatment. So you have to continue immunotherapy in adjuvant setting. And margins are negative, so no need to give radiation.
So I think my question is that I think the molecular testing has to be done in the pre-operative biopsy report instead
Yes,
of
yes.
post-operative. That will determine the adjuvant setting treatment, whether we have to give immunotherapy along with chemotherapy or only immunotherapy. Isn't it?
Yes.
Right.
EGFR and ALK, if you have CT3 and 2, then definitely you have to do it upfront.
Yeah, our radiation is completely out. We have to give only immunotherapy and chemotherapy depending upon the PDL and EGFR mutation status.
Okay. So, I hope the
So
patient.
just one question to the oncologist. Sorry, just because we are also getting more and more knowledge. So as if you're going to go to the previous slide, so there was mentioned like if EGFR is positive, you give osimertinib, and if it's PDL1 positive, you give pembrolizumab. That's immunotherapy for 1 year. So what they were saying, ki after the surgery also means along with this, we have to give 4 cycles of chemotherapy.
Look, you have CT3 and 2 disease. You have tested for EGFR, ALK, and PDL1. So if EGFR is positive, then we don't give immunotherapy in neoadjuvant setting. Once EGFR is positive, immunotherapy will not work. It is a resistance mechanism. We don't give immunotherapy. Now we have data for osimertinib, that is TKI in neoadjuvant setting. So currently we give chemotherapy plus minus TKI as a neoadjuvant treatment, and then it should be followed by only TKI in adjuvant setting.
There's little, just means you had given a neoadjuvant chemotherapy pre-op, you did the surgery, and after that the reports are positive. Like example, if EGFR is positive, so you just
So
give
if
osimertinib, or you
yes,
also give 4
if you
cycles
have
of.
given 4 cycles of chemotherapy before surgery, then there is no need to give adjuvant chemotherapy.
And if you have not given it, then you have to give 4 cycles of
Yes,
chemotherapy,
yes,
irrespective of the EGFR is means if
yes,
EGFR,
yes.
even if it's positive.
You have done upfront surgery, then you have to give chemotherapy for 4 cycles, and then it is followed by TKI.
So means chemotherapy is not out when you have
any tumor above 4 centimeter or other high risk features in histopathology like LVI, PNI, you have to give adjuvant chemotherapy.
Okay.
So in conclusion, you can say chemotherapy you have to give. Either you have to have immunotherapy or TKI. That is the addition depending upon the PDL1 status.
Yes.
So just to simplify,
Yeah. Thank you.
So I believe that's the specimen which was taken out, Dr. Sukhram. Okay, we have a very quick one. I think it's already 1.5 hours and we didn't felt at all. The discussion was going on so lively. We'll quickly run through this. 34-year-old lady evaluated for chronic cough. CT was done at a local place which showed some left lung lesion, and a PET CT showed multilobulated soft tissue density in left lung upper lobe with transfissural extension. There was erosion of the left fifth rib also. Mildly FTG avid para-aortic and left hilar lymph node suspicious for METs, and there was no other FTG avid visible disease elsewhere in the region of the body surveyed. Sorry. This is the imaging. Okay, so biopsy was done. I believe this must be a CT guided biopsy, which was squamous cell carcinoma. EBUS FNAC was negative for all the N3 and N2 nodes. So so this was T4 N0 M0. Patient refused for neoadjuvant, left pneumonectomy and chest wall resection with lymph nodes. What is SM? Lymph nodes were done. Reconstruction with proline mesh and rib plates and latissimus dorsi muscle flap. Final biopsy was poorly differentiated squamous cell carcinoma, PT4, PN0, all margins clear. And NGS EGFR amplification was there. PDL1 was negative. So patient completed post-op RT and then 4 cycles of gemcitabine and cisplatin and had an endotracheal recurrence after 1 year. So this is completely out of our hand. This is the oncologist friends who have to deal with. Please tell us your opinion about this.
So this was a T4N0M0 post-surgery, and patient got post-op radiation and followed by 4 cycle of gemcitabine cisplatin. I don't know why the adjuvant TKY is not added, even though it was EGFR mutated, amplified in that case. So might be because of the financial issue. But now the patient endotracheal recurrence after 1 year, we don't know what was the margin status at the stump. Though the patient might have received radiation with considerable dose and might have radiation, means he might have this patient have received radiation dose to the stump along with lymph node. So now the patient had recurrence. So I don't know whether it was R0 R1 resection. Now, if the patient has anything and now recurred, then the definitive management is to go with PET-CT again, that whether disease is localized or metastatic, and again the surgical call that reoperate on that means recurrence if it is localized.
You are muted. You are muted, Dr. Sukhram.
Yeah, ma'am. So there was one point which you were asking, what is SMLD? That is systemic mediation lymph node dissection.
Okay.
So in this case scenario, it was R0 resection. All margins are clear, negative, all lymph nodes were negative. We gave radiotherapy to local site.
Mm-hmm.
Now her recurrence was on we did left pneumonectomy. Her recurrence was there on the endotracheal. Endotracheal. It's not even at the stump. It is endotracheal.
Endotracheal.
That was yeah, ma'am. She had recurrence around 1.5 centimeter above the carina on the in the trachea.
Okay.
It was a pedunculated growth which was there in the after 1 year. We did PET scan and only lesion which was FDG evid was in the endotrachea. It was 1.5 centimeter above the carina for some reason. And finally, we did debulking of that thing, and the radiotherapy was given to the local site again.
Okay.
And we refer to again to the MedOnco to give the whatever further they can help with how they can help. So they suggested you get at the local radiation, and then we'll see how it is faring.
Okay. So I just wanted to ask Dr.
So 3 months. It was done in the May. And 3 months down the line, we did repeat PET in the August, and it is negative. So now she has nothing in the endotrachea.
Okay.
Yeah, and local site is still negative.
Right. So Dr. Chandrashekhar and Dr. Deepak, do you think if the patient would have agreed for neoadjuvant therapy, it would have been better? I mean, before surgery, or we cannot predict who will recur?
No, definitely, ma'am. If the tumor size is more than 4 centimeter, you have to give neoadjuvant treatment. There is very strong data, plus minus immunotherapy depending on patient's finances. But yes, if affording, then definitely immunotherapy has to be given with chemotherapy. First thing. Second thing, if your margins are negative on histopathology, you don't need to give radiation in lung cancer. There is no data for this thing. If margins are negative, there is no strong data to consider for adjuvant radiation as of now. Third thing, very rare to get, EGFR in squamous cell carcinoma. Most of the time we see in adeno-C only. But yes, if you are getting an EGFR mutation, then obviously you have to treat it, whether irrespective of histology. So you have to give adjuvant TKI if patient was affording. And after recurrence, even if it is small, resectable, you have resected, you have to give some sort of systemic therapy to lung cancer patients. Because this is a disease which is a systemic disease nowadays. Lung cancer is treated, whether it is localized or loco-regional, it has to be treated as a systemic disease. So you have to give systemic therapy.
Yeah, I agree with Dr. Chandrashekhar. And this patient has a different lesion from the previous one. It is not a local recurrence, it is a skip lesion from a distant lesion. So, and I think we have again did a R0 resection. So what was the means restaging of that tumor? Means either it was T1, T2 like this, or means giving again re-radiation in that scenario. I am still dicey. Means why the re-radiation is done in that patient again within 1 year.
So re-radiation is not done on the same area. It is for the tracheal part, which is away from the main side. The first of all, she refused for the chemotherapy, neoadjuvant, because she was feeding the baby. It was around 4 months of old baby, and she said, anyway, I'm going. I want to feed her for 6 months, and then we do the whatever radiation, chemo can be started after that. So that was the main reason for her to go for the upfront surgery.
Right, right.
Once we
So
did
this is basically a special case scenario. Yeah.
Yeah, it is a special case scenario because we did not. I mean, she was hell-bent. I'll feed my baby for 6 months. Anyway, I'm going. I will not be there after some times. She understood that this is a bad disease and it will not be. She will not be continuing forever. So she said, "Ki at least it is her baby's basic right. Ki 6 months I should feed her." So once we did the surgery and 1 year it was fine. And 1 year later, I mean, we did first PET at 3 months and then at 6 months and then 1 year. So 1 year PET, there was a FTG evidence in the trachea. So we had FDT and what should be done. They said if you are able to debulk it, then we'll see what we can do. So we did debulk and we were finding it what it is. So it was turned out to be squamous cell carcinoma. Now the question is whether she had a endotracheal again the second malignancy, squamous cell malignancy. That is we have no way to confirm it what it is. So it was MDT. They said the local this site is away from the what was previous site. We can consider radiotherapy. So they gave the radiotherapy as per their protocol. And the second thing, what was we sent patient for the systemic therapy, and she did receive the systemic therapy. I am not aware how much they have given, what they have given, because that is the domain of the med onco. But 3 months down the line, we didn't no disease as of now.
Right, right.
Right, it's nicely managed.
Yeah, I think very localized malignancy. I just wanted to ask if it's a very localized metastasis, single metastasis, just removing it is enough, or you need to give radiation and chemo?
Ma'am, I mean, locally or the distant?
Distant.
Ma'am, distant, if it is resectable, usually recurrence should be treated by the, adjuvant therapy, not by the surgery. It should be treated by the adjuvant therapy.
Okay. No, sometimes if you have just a single met, then people do operate.
We can take it out. If it is we are resectable and we see there is nothing else in the body, and if it is resectable, we can consider that.
And it all
depend on where
it is. Like this one was endotracheal, we were able to remove it. So what I want to say is it has to be always followed by the systemic chemotherapy or immunotherapy, whatever the oncologist friends decide.
Yes, ma'am. It is a systemic disease, ma'am. It is a systemic disease because there's no, it's not local recurrence. It has gone from somewhere to that place.
Yes.
So it is a systemic recurrence.
Right.
So in that case, ma'am, you can consider giving high dose radiation in the form of SBRT. Dr. Deepak will elaborate more. So suppose you have single liver metastasis of size, let's say 2 centimeter. Mm-hmm. So in that case, you can go for SBRT to that metastatic site, oligomets or single met site, and then you can continue with your systemic treatment.
Okay.
Yeah, I agree. I think SBRT and surgery both are equivalent, has shown equivalent result. So either of both can be chosen if this mets is a small, less than 3 centimeter or 2 centimeter like this. So both can be chosen and has a equivalent report. But if the met size is more and it is means metastasis is quite large or in multiple, then you have to go systemic therapy or go with surgery, depending upon case to case basis.
Right. Yeah. So I think we hope that this patient get free of her disease and be with her child for a longer time. And with this, we finish our case-based discussion and today's webinar as well. I thoroughly enjoyed it because the discussion was the cases were very good and we learned from those cases. I want to thank all our panelists for their active participation, and I learned a lot, and I believe the audience would have enjoyed as well. I do not see any question in the
Can I
chat.
ask one question, ma'am, to
Please,
the
Prajay.
oncologist exactly?
Yeah.
So, there is one thing which is there that is called liquid biopsy. Sometimes, like if the patient is not willing for a repeat procedure, then the oncologists come into the picture and then they come and just write, I mean, they write it down most of the times that if you're not, then you can go ahead with the liquid biopsy. So I just want to ask them how sensitive or specific this test is and how can it change the prognosis also?
Yes, so nowadays recommendation is to send sample, I mean tumor tissue as well as liquid biopsy for upfront NGS, and there are very strong concordance with these two modality of test, whether you send tumor tissue for NGS or liquid biopsy. So as you rightly pointed out, many times after progression or recurrence, patient are reluctant for repeat biopsy, but ideally it should be done. There are several advantages of repeating biopsy because there might be sometimes histological transformation from non-small cell to small cell, although it occurs in very small proportion of patients, but it can happen. And once there is histological transformation, then treatment changes in all scenarios. But yes, if patient is reluctant for biopsy, then you can send it through blood, that is liquid biopsy, and it has very high concordance rate.
Thank you.
Okay, so just one last comment from each one of the panelists before we bring this to conclusion. Dr. Chandrashekhar.
Yes, ma'am. Very, very nicely moderated session, ma'am. I thoroughly enjoyed your session and learned a lot of things. And as you rightly said, we see frequently very young patients of lung cancer, non-smokers, particularly female patients. I have several patients who are in their 30s, in their 20s, and they have stage 4 adenosine lung. So it is always a good thing to keep in our mind when we consider differentials. Malignancy should be ruled out in all cases, and we should approach every case like that only.
And I believe when we are looking at more precision medicine, then why shouldn't we be looking at getting a definitive diagnosis rather than treating the patient on just,
Yes, yes, exactly, ma'am.
probability basis? Dr. Sukhram.
So one thing I would like to add, we practice in Ranchi. It is a tier 2 or tier 3 city, you can say, in Jharkhand. So I have never seen a lung cancer patient who has come to me straight away without taking anti-tubercular therapy. And most of the time it is prescribed empirically. So this is a wrong thing. So we need more awareness in that area.
Agree completely. Dr. Sukhram.
Ma'am, it's wonderful interacting with you, and I enjoyed the thoroughly discussion with all the panelists. So, in one line, if I have to say, every lung cancer should be dealt with the MDT, with the discussion with all your concerned parties, and then take the final decision. You may have the multiple point of views and multiple things, because I think I do the best. Same way everybody think everybody is doing best, but together we can do the 1 + 1 is 11. So we can do better.
Certainly. Agree completely. Dr. Deepak.
Yeah, I think this session was really informative and very nice, and means I learned a lot. Especially case number 2 was really mind blowing. So this shows the means benefit of interacting with the pulmonologist and taking in the MDT. So really nice, ma'am. And we also see in the future that keep this interactive meeting with us so that we can know what else we can do. Yeah. Thank you, ma'am. Very nice. Yeah. I enjoyed a lot.
Yeah. Dr. Prajay.
So, ma'am, excellent moderation as usual you do every time. So, and excellent sharing of the knowledge by all the panelists. Great to learn from the surgeon and the oncologist. The only take-home message to everyone is like, whenever you are doing a biopsy, even if you feel it's the malignancy, always send the samples for culture and the gene expert. And sometimes the LPA might be helpful in some other patients. So that is.
Yeah, and that's a message to Dr. Sukhram also. Please, all the surgeons out there, there's a loud cry from the pulmonologists. Please send us samples for cultures as well. Dr. Gaurav.
Sure, ma'am.
Ma'am, very well moderated. Thank you for such a beautiful, wonderful moderation. And we have learnt a lot and very good cases. Even by sir, such a wonderful surgery sir is doing. That was remarkable. And we have learnt a lot. Dr. Prajay, cheers. We have so we have put a lot of strain on them that what should be done and that should be sent. So one thing we'll tell them that whenever you do ask your pulmonologist to do any biopsies and all, just send a battery of tests because once you are in the bronchus or you are in the pleura, don't leave anything behind.
Yeah.
Just let it go out with everything that we have a diagnosis to work on.
Thank you, everyone. With this, we will close our session. And before I close, I would like to thank CCI for giving us this a platform for interaction, and also the academic partner Cipla, who has been wonderful to provide us this partner. And before we sign off and say good night, wishing you all a very, very happy Dussehra.
Happy
Good
Dussehra to
night.
everyone.
Happy
Happy
Dussehra.
Dussehra. Happy Dussehra to all.
Thank you.
Thank you.
Thank
Thank
you.
you.
Thank you.